Welcome back to the deep dive. Today, we're getting to grips with, well, probably the highest stakes area of your professional life: clinical governance, safety, and accountability.
We've got a whole stack of sources here: GMC, good medical practice, some really specific SJT guidance, and even the latest updates on incident reporting, like LFPSC.
And our mission for this deep dive really is to help you move beyond just, memorizing the rules.
Exactly. It's about internalizing the exam logic. That's the key. It's a kind of operational framework that always prioritizes safe, auditable, and structured action, especially when you're under huge pressure.
Yeah, because what the sources show time and time again is that the high-scoring actions, both in the SJT and just in real life, come from choosing that safety and structure over what's easy or what the hierarchy wants.
It's the difference, isn't it, between an ownerless critical result and a task that has a named clinician, a clear deadline, and a record you can actually follow.
So today we're going to try and synthesize all of that and give you some specific, memorable mnemonics and frameworks.
The goal is that by the end of this, you should be able to approach any scenario of delegation, escalation, and incident with, well, immediate and structured confidence.
Okay, let's just dive straight in with one of those classic tension-filled scenarios, the kind that really tests these frameworks to their absolute limit.
Go on.
So imagine this. It's the end of a long, really draining shift, 12 hours. You're just desperate to sign off and go home. You've been managing this really complex patient, a new septic admission who's now on NIV, still acutely unstable.
And you look over and the relieving night team, they're just swamped. You can see they're short-staffed, struggling to even answer the urgent bleeps.
You're doing your final check of the patient's notes just to get the handover done. And then you see it, a critical lab result, a lactate of 6.5.
Oh, it's a big number.
A huge number. And it came back 2 hours ago. It was flagged, but in the rush of the last hour, nobody, not even you, has acted on it. It's not even on the written handover list. It is completely, totally ownerless.
Right. And the risk there is just enormous. Your professional duty is screaming at you to do something, but every instinct is just saying, I need to go home, the night team is too busy, maybe I can just...
Exactly. So what's the immediate high-scoring professional action? I mean, do you quietly try to fix it yourself? Phone the lab, maybe save the night team the hassle?
Or do you jot a quick note in the file and just hope someone sees it?
Or do you follow a really rigid protocol that you know is going to guarantee accountability, even if it means you're stuck here for another 30 minutes?
And that question, right there, is the answer. The core truth that underpins everything we're about to discuss is this: clinical governance and SJT scoring will always, consistently reward the actions that immediately secure patient safety.
And those actions always use structured communication.
They transfer accountability to a named owner.
And they create a clear, factual, auditable trail that the whole system can learn from.
That's the whole game right there.
Let's really unpack that.
Yeah.
Where does this all start? Where does this professional duty come from?
Well, it starts with the absolute foundation, which is the GMC mandate. It's spelled out so clearly in Good Medical Practice 2024.
Right.
The bedrock principle, you can find it in paragraph 15, is totally unambiguous. It just says, patient safety is your first concern.
It's not a suggestion.
It's not negotiable, full stop. When safety clashes with anything else, your time, convenience, hospital targets, even seniority safety has to win.
And why does that matter so much? I mean, it seems obvious, but what's the clinical reality?
The reason is that when you look at serious avoidable harms, they almost never come from malice or even, a doctor just being incompetent. They come from system failures.
Things falling through the cracks.
Exactly. Yeah. Missed information, tasks without a clear owner, and actions that don't have a timeline or review point. Our frameworks, all these mnemonics we'll talk about, are designed specifically to close those three gaps.
And I suppose the most common place those gaps appear is in delegation and supervision. I mean, as a junior doctor, you're delegating things all the time.
Constantly. But here's the high-yield concept, the thing the SJT loves to test. Delegating a task doesn't mean you've delegated the responsibility for safe patient care.
So you can't just pass the buck.
Never. The principle is you transfer the task, but you absolutely retain the oversight. That's the supervision part. If you ask a student to do something and they do it unsafely because you didn't check if they were competent or you gave unclear instructions,
that's on you.
The accountability for that failure comes right back to you, the delegator.
Okay, so we need a system, a really rigorous one, to make sure delegation is safe and, as you said, auditable. Which brings us to the famous 5 rights of delegation. For anyone listening, you have to get this checklist into your head.
Let's walk through them. And let's think about a specific task, something a bit complex. Say you're asking a student nurse to monitor a blood transfusion for signs of a reaction. That's a task that needs knowledge and real vigilance.
Okay, so first up, the right task. Is this task even appropriate given the patient's condition and the risk?
Right. Monitoring transfusion is probably okay. But asking them to start one on an unstable patient without you standing right there? Absolutely not. That's the wrong task.
Okay, makes sense. Second, the right person. Now, you said this is where people fall down.
This is the big trap. You absolutely must verify their competence, their training, their scope of practice. You can never, ever assume.
So what does that look like? You can't just say, are you competent? It sounds a bit rude.
The high-scoring action is always to ask an open-ended question. Something like, can you just quickly talk me through the steps you take when you're monitoring a transfusion? Specifically, what signs would make you call me straight away?
Ah, I see. So you're checking their knowledge without being confrontational. That's clever.
It confirms competence way better than a yes-no question.
Okay. Third is right instructions. The sources say they have to be closed loop, explicit, and have clear escalation criteria. That sounds like a lot.
It is, but it's crucial. The difference between a vague instruction and a high-scoring one is just immense. You don't say, just watch the transfusion.
What do you say?
You say, please monitor the patient's vital signs every 15 minutes for the first hour. Call me immediately on this bleep number if their heart rate goes up by 20, their temp goes above 37.8, or if they get short of breath. I want a verbal update from you in 30 minutes.
Wow. That's incredibly specific.
It defines the ask, the timeline, and the safety triggers. There's no room for misunderstanding.
Okay. Fourth is right supervision. So the oversight has to match the risk and the person's competence.
Yes. If it's a high-risk task, like that transfusion, your supervision has to be direct, or at least easily accessible. And it's not passive. You have to actively check in. Maybe you set an alarm on your phone to remind you to call them back in 30 minutes.
And the final one, number 5, the right record. Documentation.
This is what turns an informal chat into a professional, auditable part of patient care. You have to write down who owns the task, the plan, the time frame, and those escalation triggers right there in the patient's notes. It protects the patient, and it proves you followed this standard.
And to help us remember all this, the sources give us the delegate mnemonic. It seems to cover the whole process.
It does. Let's just quickly break it down. D is for delegate. Define the task clearly.
E is evaluate competence, that check you mentioned.
L is for the level of supervision needed.
E is explain and check back, so they've definitely understood.
G is give resources the equipment they need, your contact number.
A is agree on times and those crucial escalation triggers.
T is track the outcome, so you actively review it.
And finally, E is enter a record of the whole thing.
And when you use that whole framework, you suddenly see why the low-scoring actions are so dangerous. They leave accountability completely vague.
Right. The classic, I saw the student hovering, so I asked her to get the ABG. I assume she's done one before.
Exactly. That ignores competence, instructions, oversight, everything. Or the one you hear on a busy shift. Just let them have a go. The registrar is too busy to teach them properly. You're putting convenience or even training above immediate patient safety. That's a direct violation of the GMC mandate. Unstructured delegation is unsafe delegation. Full stop.
That same structured thinking, it must also apply when you're prioritizing. You know, you've got all these competing demands, the ward round isn't finished, theaters are calling, and then suddenly you've got a patient with a NUWS of 8.
And this is where prioritizing patient safety has a head-on collision with all those systemic pressures. The SJT just loves to test your willingness to choose safety, even when it means you have to challenge a senior or mess up the workflow.
Let's talk about that specific, really difficult one, challenging a senior. So say you're a consultant who's stressed about bed pressures, tells you to just hold off escalating that new WS8 patient because they want to get the discharge letters done first. Or they say, oh, he's always a bit tachycardic.
This is where that structure and documentation becomes your shield. You have to, respectfully, but really firmly, reiterate the risk. And the best way to do that is using SBAR, which we'll cover in more detail soon.
So you state the clinical facts?
You state the facts, the heart rate, the respiratory rate, the deviation from their normal, and the immediate danger that represents. Then, this is the critical high-scoring action, you state your intention to escalate to the next appropriate senior if they can't address the risk right now.
So the conversation isn't aggressive, it's just professionally assertive.
Exactly. Something like, Dr. Smith, I understand how much pressure we're under, but this patient's new WS score means they need an immediate critical care review. If you're not able to review them in the next 10 minutes, I'll need to call the duty consultant and the site team to make sure this risk is managed.
And by doing that, you've shown you acted, you followed the protocol, and you've documented that you're climbing the chain of command because your duty to the patient comes before any kind of hierarchical comfort.
Precisely. The low-scoring option is always to just quietly accept it and wait and see. That's a failing answer.
Okay, so to structure that decision-making process when you're under that kind of acute pressure, we have the first mnemonic.
First is your rapid-fire checklist for these high-acuity situations. Yeah. F is for flag the risk. Recognize the new WS score, the lactate, whatever the red flag is.
As for intervene, your immediate ABCDE, actions, oxygen, IV access, those time-critical drugs.
R is raise or escalate. Use SBAR to call the right senior, and then the next one up if you get blocked.
S is secure the record. You document what you did, why you did it, and who you spoke to.
And T is track the outcomes. You don't just escalate and walk away. You have to make sure the patient actually gets reviewed and the risk is dealt with.
The power of first is that it forces you to create that auditable trail. It shows you stuck to good medical practice and acted promptly when safety was on the line.
Yeah, that's it.
And that discussion about challenging seniors leads us perfectly into the mechanics of escalation itself. I mean, we do it all day, every day, but if it's unstructured, it can just be dismissed or misunderstood, and that leads to disaster.
The central rule for a high-scoring escalation is that it has to be early, it has to be structured, and it has to be auditable.
Yeah.
Your first job, always, is to intervene within your own competence, stabilize the EBEs, get the sepsis 6 started, and then you call someone with the authority to take the next big steps.
So let's detail those steps. The sources give us 5 high-scoring actions. We've kind of covered the first 2. Recognizing the risk like a high new WS2 score and intervening with ABCDE. Let's focus on the communication part.
Okay, so step 3 is probably the most important of all. Call early using SBARs. We just can't stress this enough. SBAR is the mandatory communication standard for clinical acuity. It ensures that a senior gets all the critical information in less than a minute, which is vital for them to make a quick decision.
Let's just quickly break down SBAR for anyone who needs a refresher.
Sure. S is for a situation. What's the problem right now? Mr. Jones is hypotensive and unresponsive.
B is background. Why is he here? What's happened recently? He's a 75-year-old post-op hip replacement, was stable until 30 minutes ago.
A is for your assessment. What are your findings? What do you think is going on? His new WS is 9, BP is 85/50, lactate is 5. My assessment is septic shock.
And R is your recommendation. What specific action do you need from them?
And this recommendation part is where people often go wrong clinically. You can't be vague. Can you come down when you get a minute is a really low-scoring phrase.
So what's a high-scoring one?
A high-scoring one is, I require an urgent review by a registrar-level clinician within the next 15 minutes to initiate central access and inotropes. You see, it's a concrete ask with an explicit deadline.
Right, there's no ambiguity there. Okay, so step 4 is also critical. Escalate the chain if you're blocked. We've touched on this, but let's just really hammer it home.
If your bleep isn't answered in 5 minutes, if you call the team and they say they can't come, or if that senior dismisses your concern, you must go to the next level. That means the duty consultant, the critical care outreach team, the site manager. Your professional duty is only fulfilled when that patient is safe.
And step 5, the end of the loop. Document the facts, the advice, and the plan.
Every single call, every conversation, every agreed deadline gets logged right then and there in the patient record. This makes sure the next person to look at the notes knows exactly who was told what and when.
And to wrap all of that up, we've got the RAISE IT mnemonic.
Yeah, RAISE IT is really comprehensive. Recognize the risk, assess and act, so you intervene.
Inform using SBR.
Safeguard the patient with immediate treatment.
Escalate the chain if you're blocked.
Incident report, so you file an LFPSC if harm happened or nearly happened.
And T, track the follow-up, make sure the plan actually happens.
The track answers here are always the passive ones. Any option that involves sending a vague text, leaving a voicemail, or just waiting for the next shift when you have clear red flags is a definite low-scoring choice.
Okay, now let's tie all of this structured communication directly back to the transfer of risk. Safe handover. We're back to that opening scenario, that ownerless high lactate.
Handover is, without a doubt, the single most common time for patients to come to harm. And the reason is because the transfer of care is also the transfer of accountability to a named person or team. If you walk off that ward without confirming that the next responsible clinician has explicitly accepted that risk, then professionally, that accountability is still, at least partly, with you.
The sources are so clear on this. A safe handover has 4 absolute non-negotiables: SBAR structure, a named owner, a deadline for the action, and a written contemporaneous record.
Miss any one of those 4, and the handover is unsafe. It will score badly.
So let's apply it to our dilemma. You find that lactate of 6.5, 2 hours old, totally ownerless.
The high-scoring action isn't to try and sort it out yourself and just write a note. It's to immediately go and secure accountability. You walk up to the relieving senior and you use SBA.
So, situation. Mr. Smith is acutely unstable, and I've just found a critical lactate of 6.5 from 2 hours ago that hasn't been acted on.
Background: he's on NIV for sepsis. Assessment: this needs an immediate fluid review and probably escalation to ICU. Recommendation: I need you, Dr. X, to take ownership of this result right now and agree to review this patient within the next 15 minutes.
And the key thing is you wait for them to actually say yes to confirm they accept it.
And then you immediately document that exchange in the notes. 18.05. Discussed ownerless lactate of 6.5 with Dr. X, night registrar. Dr. X accepted ownership and agreed to review the patient within 15 minutes. That is a safe transfer of accountability.
And that rigor is captured perfectly in the ONAD mnemonic.
Yeah, ODA is designed just for this. Outline the plan and risks using SBR.
Who owns it? You get that named clinician.
Notes are written right then and there.
Intervals and timeframes are set. Deadlines.
And T, the trigger to escalate. What criteria would make the new team call the consultant?
And you can see straight away why the trap answers like I'll pop it in the group chat or just writing for urgent review with no owner just completely fail. They're informal, they're not auditable, they protect no one.
Not the patient, not you, not the team.
Okay, so we've established how to prevent harm with all this structure. But what happens when, despite everything, harm or a near miss still happens? This takes us into the world of integrity and incident reporting.
And this is a massive, really high priority topic at the moment because of the huge systemic change that's happened in England. The sources really detail this mandatory shift away from the old NRLS system to the new LFPSC, like learned from Patient Safety Event Service, and the rollout of PSIRF, the Patient Safety Incident Response Framework. If you're listening to this, you have to understand this new mindset.
Okay, so PSIRF, let's unpack that. What does it actually mean for a junior doctor on the ward who has to report an error?
It means a fundamental shift away from a blame-focused culture. The old way, an RCA or root cause analysis, often just focused on the individual who made the mistake. PSIRF is all about system-focused learning with a proportionate response. The core principle is you report to learn, not to blame.
So if a patient gets the wrong dose of insulin by mistake, the system is less interested in pointing the finger at me, the individual doctor who prescribed it.
And more interested in why. Why did the electronic prescribing system allow that dose? Why did the pharmacy dispense it without a query? Why does the nurse checking it spot the error?
So it's about finding the hazard in the system itself.
Precisely. The goal is to find and fix that systemic hazard so the same mistake just can't happen to the next patient. And this applies just as much to near misses.
Right, they have to be reported.
You must report near misses promptly using the LFPSC system. They are flashing red lights, warnings of a system problem that, if you ignore it, will absolutely cause real harm down the line.
So what are the high-scoring actions when you're managing an incident? There must be a sequence.
The sequence is critical. First priority, always. Immediate clinical safety. Make the patient safe before you even think about the paperwork. If it's a drug error, you stop the drug, you manage the patient's vitals, and you tell your senior immediately.
And then second is the factual, timely reporting.
As soon as that patient is stable, you submit a factual report to LFPSC. And it has to be objective facts: who, what, when, where, and what immediate actions you took.
And critically, you avoid any blame or speculation.
Absolutely. You don't write, Dr. Smith seemed tired and prescribed the wrong dose. You write, patient received 10 units instead of 1 unit of X drug due to a selection error on the electronic prescribing system. Factual.
And the third step, the vital link to the duty of candor.
Yes. GMC guidance, paragraph 23, is very clear. If something goes wrong that causes, or even just has the potential to cause, harm or death, you have a duty to be open and honest with the patient.
And that candor process, it involves explaining the facts as you know them.
Offering a sincere apology.
And reassuring them that a proper review is happening and that they'll be kept in the loop.
Yes. And we can structure this whole response with the report mnemonic.
Okay, let's hear it.
So, report. Reduce risk. That's your immediate safety action. Explain, which is fulfilling your duty of candor.
Present facts in your factual report to LFPSC.
Oversee escalation, making sure seniors and management know so a review can happen.
Remedies and learning, so you contribute to fixing the system.
NT timestamp. Make sure all your records are contemporaneous.
Okay, and the trap answers here are all about delay or blame. So why is wait until the system is fixed before reporting a bad answer?
Because the reporting is what triggers the fix. If you wait, you're allowing that hazard to continue to exist, potentially harming other patients.
And what about find the person responsible and tell management?
That's a trap, because it actively undermines the entire goal of PSIRF. It fosters a blame culture, not a learning culture. We report the event, not the person.
That concept of candor flows so naturally into the next topic, responding to patient complaints. Often, that's all a complaint starts as a need for an apology and an explanation.
Absolutely. The sources frame complaints not as a legal threat, but as essential feedback. And there's a key distinction here, one the SJT loves to test, because it hits on a common fear among doctors. It comes from GMC Good Medical Practice, paragraph 45.
And that is?
A sincere apology does not, of itself, admit legal liability.
That is such a huge professional relief to hear. It means you can be a human being, you can be professionally correct, and you don't immediately open yourself up to legal risk.
Apologizing for the patient's experience, their distress, their confusion, is always the high-scoring action.
Okay, so what's the high-yield, structured way to handle a complaint, whether it's verbal on the ward or a formal letter?
Step 1, as always, stabilize immediate risk. Make sure the patient is safe right now. Step 2, listen and acknowledge their distress. Give them your full attention. Show genuine empathy. Don't get defensive.
Step 3, apologize and explain the known facts in the next steps. Say you're sorry for their experience. Tell them what you know for sure, and promise them that you'll find out more and that it will be reviewed properly.
Then step 4, you have to signpost the formal routes. You must clearly direct them to PARAS, the Patient Advice and Liaison Service, or your local complaints manager. Give them the contact details.
And finally, step 5, document the conversation and file an incident report. If the complaint brings up a safety issue, it becomes an LFPSC incident, and that documentation must be objective and factual.
And the mnemonic for this very empathetic but structured response, is repair.
Okay.
Risk safe now, patient stability. Empathize, listen, and acknowledge.
Provide an apology for their experience.
Account of facts and the next steps.
Inform them of the routes, like
R&R, record and learn. Document it and file the incident report.
The low-scoring answers here are always the ones driven by fear or defensiveness, avoiding saying sorry because you're worried about litigation, or, even worse, blaming another team or person. Professionalism demands candor and accountability.
It does.
Okay, so our final section. This deals with what feels like the highest level of professional courage, protecting the whole system by speaking up or whistleblowing, and intervening when colleagues are unsafe.
This is where patient safety completely transcends any hierarchy or loyalty to your team. The GMC is crystal clear. You have a duty to act, and act promptly when you believe patient safety is being compromised, even if that concern is about a senior colleague or the hospital itself.
But that's so hard to do in practice. I mean, it's incredibly intimidating to challenge your consultant, especially if you're a junior doctor just rotating through. So what's the safe, auditable way to escalate if your concern, say, dangerously low staffing levels causing critical delays is just being dismissed by your boss?
You have to use the formal escalation path. You always start locally, with your immediate senior. But if that fails, you have to climb the ladder. So immediate senior, then the duty consultant or the clinical director, and if that doesn't work, you go to the Freedom to Speak Up Guardian.
The FTSU Guardian.
Yes. This is a statutory confidential resource, and it's specifically designed to support you when those local reporting channels are blocked, or if you're afraid of retaliation. Using the FTSU Guardian is always a high-scoring action when that internal trust is broken down.
So the trap is stopping after that first attempt. If the registrar just says, look, we're all tired, just get on with it, your professional duty is to go over their head to the consultant or site management until that risk is actually addressed.
Stopping after the first rebuff means the risk is still there. You haven't done your job. And again, structure makes these difficult conversations safer. You must document the facts. An SBAR of the risk, who you spoke to, what time, what they said, and why you had to escalate it further. That paper trail protects you.
And we can structure this response with the SpeakUP mnemonic.
Yes, SpeakUP gives you that framework in a crisis. See the risk, present the facts using SBIR, escalate up the chain, ask for FTSU support if you're blocked.
Keep records. Understand your local policy. And P, persevere. Don't stop until the risk is gone.
That's it.
We should also just explicitly talk about the low-scoring pitfalls. Why is going to social media or the press never the right first move?
Because it breaches patient confidentiality, it's unprofessional, and it bypasses all the formal legal protections that the Public Interest Disclosure Act and the FTSU framework give you. Those channels are there to protect you while addressing the risk safely. You use the system that's designed for learning, not for public shaming.
And finally, we have to turn to what is maybe the most difficult scenario of all, dealing with unsafe colleague behavior. This feels like it needs a balance of immediate patient safety and a compassionate approach to the colleague.
It does. When you see unsafe behavior, maybe you suspect impairment from alcohol or extreme fatigue, or you see repeated serious errors, the core duty is immediate risk control. Your #1 priority is to halt their clinical duties and remove that colleague from patient contact. Safety first, investigation comes later.
And the immediate action has to be formalized. Who do you tell?
Someone with the authority to start a formal investigation and also provide support. So the duty consultant, the clinical lead, or the site manager. And it must be a confidential, formal escalation. Not gossip, not a team WhatsApp group, not an informal chat. Confidentiality is paramount here to protect the colleague and make sure the process is fair.
And the follow-up has to include support.
Always. Once the immediate risk is contained, the process must engage support mechanisms, occupational health, the GMC, maybe supervised training plans to ensure fair treatment and remediation.
The structure for this incredibly sensitive action is the ACTID mnemonic.
Yes, ACTID helps you balance safety and integrity. Assess the risk, is the patient safe right now? Cease the unsafe duty, remove the colleague from patient contact.
Tell a senior, formally and confidentially.
Engage support, like occupational health. And D, document it. An objective, factual record of what happened and what you did.
The low-scoring options here are trying to keep it between us because you feel sorry for them, or publicly confronting them. Both of those are wrong. The safe and professional action is always confidential intervention and formal escalation.
Every time.
Okay. We have covered an immense amount of ground there, from delegation and escalation right through to incident management and protecting the whole system. These frameworks are really your tools for navigating the pressure cooker of clinical practice. Let's try and reinforce the core SJT logic with a rapid-fire review.
Let's do it. These are the patterns you need to have ready to go.
Okay. If you delegate a high-risk task, like chasing a critical blood result for an unstable patient,
You use the right framework. Verify competence, give explicit instructions with a deadline and an escalation trigger, and document that transfer of ownership. If no one's available, you do it yourself first.
If a time-critical antibiotic is due, but the patient needs 4 other urgent things done,
You give that time-critical antibiotic yourself, immediately. Intervention within your competence. Then you structure the rest of the tasks using delegate or first. Safety always comes before process.
if a senior dismisses your concern about a patient's declining GCS, saying they're just a bit sleepy,
You escalate immediately to the next level of authority duty consultant or site team. You use structured SBR, and you document the whole exchange, including the senior's refusal, using the first mnemonic.
if a near-miss drug error happens, say the wrong concentration is drawn up but not actually given,
You make sure the patient is safe, then you file a factual LFPSC report immediately. Near misses expose system hazards, and PSIRF demands they're reviewed. Use the report mnemonic.
if you hand over a critical patient who needs OBS every 30 minutes,
Use ONAD. You name the specific clinician who accepts responsibility, you confirm that 30-minute interval, and you make sure that plan is written in the notes before you walk away.
and if a patient complains that your colleague was rude and it led to their care being delayed,
You use repair. You listen with empathy. You apologize sincerely for their experience without admitting liability. You explain the next steps for the investigation, and you signpost them to PALs.
Okay, let's consolidate all of that with our 3 essential takeaways.
Number 1, safety first, structure always. All the high-scoring actions prioritize immediate patient stabilization, and they all rely on standardized structure, SBR, ONI, report. Structure is what guarantees reliability and clarity.
Number 2, document accountability. Professionalism means visibility. Every critical decision, every delegation, every escalation has to be recorded right there and then with a named donor and a specific time frame. If it's not written down, it didn't happen, and accountability is completely lost.
And number 3, escalate the chain. You never, ever stop at the first barrier, whether it's an unanswered bleep, a system that's not working, or a dismissive senior. Patient safety dictates that you must escalate to whatever level of authority is needed to fix the risk consultant, site manager, or the freedom to speak up guardian.
Mastering these complex frameworks, right? Own it, raise it, report, repair, ACTID. It's really the cornerstone of safe medical practice. It's about making the choice to be the safest doctor you can be, even when the system is pushing you to just be the most convenient.
And that commitment to structured, accountable, and auditable care is the foundation of a high-integrity medical culture. And of course, it's your key to excelling in these professional assessments.
If you do need more structured practice scenarios, detailed explanations, and specific guidance on applying these high-yield mnemonics for your exams, be sure to check out the target resources over at passthemsra.com.
Keep all those frameworks close. They're your professional toolkit.
Until the next deep dive, stay safe and stay structured.